contact, and this will enable the activation of factor number 12. Then this will enable, or this will activate factor number 11, and this will activate factor number 9. Along with calcium, platelets, and factor number 8, factor number 10 will be activated. So in the extrinsic pathway, we are talking about tissue factor, or factor number 3, and factor number 7. In the intrinsic pathway, we are talking about factor number 12, 11, 9, 8, and along with calcium and platelets. After that, upon the activation of factor number 10, so we have reached the common pathway. Once factor number 10 has been activated, so prothrombin will be converted to thrombin, as if the prothrombin is the proactive or inactive form of thrombin. So activation number 10, factor number 10 will convert prothrombin to thrombin. Now, thrombin has two major important functions. The first one is the activation of fibrin from fibrinogen. Fibrinogen is the inactive form of fibrin. And the other one, which is very important, is the conversion of factor number 13, which eventually will stabilize the fibrin formation. So we have the extrinsic pathway, factor number 3, factor number 7. We have the intrinsic pathway, 12, 11, 9, 8, along with platelets and calcium, will convert, will activate factor number 10. Now, factor number 10 will convert prothrombin to thrombin. Thrombin has two functions. The first one, which is very important, is the conversion of fibrinogen to fibrin. And then the other function is just to stabilize the fibrin clot. Do you have any questions at this moment? Okay, I'm going to continue.
Dear Dr.
Okay, in this diagram, it's showing, it summarizes the coagulation pathway. So in extrinsic pathway, we talk about tissue factor or clotting number, blood clotting factor number 3 and 7. This is the extrinsic. And the intrinsic, we talk about 12, 11, 9, 10, 8, along with calcium and platelets. Once we are talking about the common pathway, so we are talking about fibrinogen, which is 1, factor number 1, 2, 5, and 10. More depth in these two. So, do you remember warfarin? Do you know any information about warfarin?
Yes, doctor, it's used after valve replacement.
Yes, but it's one of the anticoagulants.
Yes, it's an anticoagulant.
One of the anticoagulants. Actually, warfarin is affecting mainly, or works mainly on the extrinsic pathway. How to monitor the extrinsic pathway? How to monitor the warfarin? The warfarin is monitored by BT, or specifically INR, which is the international normalized ratio. If a patient is having a history of valve replacement or DVT or something like this, what will happen? They are giving that patient warfarin, but they need to monitor the warfarin. How to monitor the warfarin? By measuring the INR. The INR should be specific, 2 to 3, or it depends on the situation and the circumstances of the patient, but usually 2 to 3. INR is part of the BT, or prothrombin time. The prothrombin time measures the extrinsic pathway. So warfarin affects the extrinsic pathway mainly. And the extrinsic pathway measured or monitored by measuring the prothrombin time. On the other hand, the intrinsic pathway, how we monitor the intrinsic pathway by the ABTT or partial thromboplastin time. This to measure or to monitor the intrinsic pathway. You know heparin infusion. Sometimes patients are given heparin infusion. How to monitor the heparin infusion is by measuring the ABTT mainly. You could monitor or what, because once you order the coagulation profile, what it includes? It includes ABTT, BT, and INR, all of them, whenever you order the coagulation profile. So why we need to monitor, we need to measure the ABTT? To check the intrinsic pathway. Why to measure the BT? To measure or to monitor the extrinsic pathway. Yes, most of the times, sometimes if the patient gets bleeding or coagulation defects or something, the patient might get both prolonged, the prothrombin time and the partial thromboplastin time. But in depth, why we need to measure the prothrombin time? To monitor the extrinsic pathway. Why we need to measure the ABTT? To monitor the intrinsic pathway. Is it clear?
Yes, doctor.
Okay. Next, this table summarizes the the name of the clotting factor and the number of the clotting factor and which area been involved, whether intrinsic or extrinsic pathway, or both of them. You are not required to recall the names of the coagulation or blood clotting factors, but you are required to know the factor, which factor been involved in the extrinsic pathway, which factor is involved in the intrinsic pathway or common pathway. So after the coagulation cascade has initiated, here we must have a balance between fibrin production and fibrinolysis, which is the final stage of the coagulation pathway. What about if a patient get a lot of fibrin production? What will happen? What will happen?
Maybe blood clots or something.
Yes, thrombosis. The patient will have DVT, will get pulmonary embolism, so thrombosis in the body. What about if the patient got like a lot of fibrinolysis, as if there is no production of the fibrin? So bleeding will have ongoing, will continue. So the patient will get an ongoing bleeding. So Subhan Rabbil Alamin, the physiologic function of the body is just to have a balance between fibrin production and fibrinolysis. If the fibrin production is higher, then the patient will get thrombosis. Once the fibrinolysis continued, then the patient will get rebleeding again. So Subhan Rabbil Alamin, we have a balance between these two factors. Bleeding disorder, I'm not going into details about this, but I would like to highlight what is the meaning of thrombocytopenia. Thrombocytopenia means there is decrease in the platelets count. So the platelets number will decrease. Once the platelets number get down, there are many factors for that, many causes for that. About the production or from early beginning in the synthesis. or sometimes no, it has been produced but peripherally get degraded, peripherally get destruction. So now we know the platelets function. It's very important. Platelets plug formation. So once the platelets function or platelets number get down, what will happen? What do you expect? What will happen? Platelets number, once the we need to give aspirin once the platelets number reaches the platelets count or number has reached above 1 million. We're given aspirin. So what is the function of aspirin? We know that aspirin is yes, it's an anticoagulant, but it's an antiplatelets. Excellent. Antiplatelets.
It works on the plug of the platelet.
Okay, but it's generally speaking, it's an antiplatelets. But suppose that the patient is having aspirin, prophylactic or therapeutic aspirin is given to that particular patient. What will happen to the platelets number? Do you think the platelets number will increase, decrease, or remain the same? The platelets number
Remain the same.
Remain the same. Do you agree with him? Do you agree or not?
No.
No. What do you think, Mohammed?
Become low.
Becomes low.
Yes.
Is there any other answers? So one of your colleagues mentioned the platelets number. If the patient is taking aspirin or on aspirin therapy, the platelets number will remain the same. The platelets number will remain the same. And another one said, no, it will decrease. What do you think?
I think that the platelet number will remain the same, but the clot formation will be delayed.
So what do you call this? So the aspirin will affect the platelets what? Function. Excellent. So we are talking about aspirin therapy that can affect the platelets function, not the number. The number will remain the same. So that's why if the patient is taking aspirin or the patient is on aspirin therapy, we cannot monitor this. We cannot say that the patient will do platelets count, for example, and it will reflect the situation, whether the patient is taking aspirin or not. For example, warfarin will order the INR. If the INR is high, and this will confirm that the patient is taking warfarin, therapeutic dose of warfarin. But if the patient is taking aspirin, we cannot tell that the patient get on aspirin based on the platelets number. But the function will be affected. Then the patient will get bleeding. That's why it's very important before the surgery, any surgical intervention to ask about the medical history, medications, and ensure that the patient is not taking aspirin. If the patient is taking aspirin, ensure that there is a specific protocol for that. What is that protocol? If the patient is taking aspirin and the patient has been booked for elective surgery.
نشوف coagulation profile.
Normal. We just said that the coagulation profile, we cannot monitor the aspirin based on the coagulation profile.
نتأكد إن ما في internal hemorrhage.
The bleeding time may be increased, okay, but what you will do? So before, and you are sure that the patient is taking aspirin. what you will ask the patient to do? What is your protocol?
Stop aspirin.
Stop aspirin. Okay, stop aspirin. Is there any other other answers? Okay, why you need to stop the aspirin? And for how long? What do you think?
10 days maybe.
10 days.
To prevent surgery أو during the surgery.
Okay, let me clarify this and put this all together. So, what is the half-life of the aspirin? Abdurrahman, you said that the patient needed to have we need to hold the aspirin in elective surgeries for 10 days. We need to delay the elective surgery for 10 days. Why 10 days?
أنا صدق أتذكرها كذا أن
Okay, so why we need to actually, in cases of emergency means emergency, we need to take the patient either way and ensure that, ensure about the hemostasis. But in elective situations, elective means scheduled surgery. So elective cholecystectomy means I'm gonna book this patient after a week or 2 weeks for surgery, for example. If the patient is taking aspirin, we need to stop or to schedule the surgery at least a week after the surgery, after the hold of the aspirin. So ask the patient to stop aspirin from today. After a week to 10 days, you need to do the surgery. Why? Because the half-life of the platelets is almost 7 days, 7 to 10 days. And you need to wait for the formation of new platelets in order to reach normal platelets. Because we cannot replace the platelets unless you do platelets transfusion, which usually not the situation if the patient is taking aspirin. Just to stop the elective, stop the aspirin and then schedule the surgery after a week. Now, these are, the differences in terms of the symptoms and signs between the differences between primary hemostasis and secondary hemostasis. We said primary hemostasis will involve vasoconstriction and platelets plug formation. That's why if there is a defective vasoconstriction or there is a problem with the platelets plug formation, spontaneous and immediate bleeding will continue, usually in this skin and mucous membrane. But what about the secondary hemostasis? If there is problem in the coagulation cascade, clotting factors, what will happen? There is a delayed bleeding after trauma. That means, because primarily the vasoconstriction is there, platelets plug formation is there, this will hold the homeostasis, or this will initiate the homeostasis for a short period of time. It will hold the ongoing bleeding for a short period of time till the coagulation cascade is well established. Then the homeostasis will be optimum. These are different clinical symptoms and signs of bleeding. It's very important to know what is the meaning of petechiae, what is the meaning of perbra, what is the meaning of ecchymosis, and what is hematoma. Hematoma is collection of blood. If, like this picture, ecchymosis is more than, or discoloration of the skin is more than 1 centimeter, this is called ecchymosis. Perbra, less than 1 centimeter, but more than 3 millimeters. If it is like pinpointed spots of bleeding, this is called petechiae. I'm not going into details about what are the different terms of bleeding, like what is the meaning of epistaxis, what is the meaning of menorrhagia, what is the meaning of hematemesis, but just this is, I'm sure that you know all of these. But just remember that melena, or blood in stool, different than occult blood in stool. Occult blood in stool, that you cannot see it. detected by special method, which basically stool analysis for occult blood. So they are looking to the stool under the microscope to check for the RBCs. But melena, it's black tarry stool, which indicates upper GI bleeding. Types of surgical hemorrhage. What are the types of surgical hemorrhage? We have primary, intermediate or reactionary, and we have secondary. Do not confuse yourself between the stages of hemostasis and types of surgical hemorrhage. There we have primary and secondary. Here we have primary, intermediate or reactionary, and secondary. So primary, it means that there is bleeding on the scene. Once the patient still in the operating room and get bleeding, this is called primary surgical hemorrhage. But suppose that the patient is out from the operating room and within 24 hours of the surgery, due to high blood pressure, the patient was coughing or sneezing, then this is labeled as reactionary or intermediate. A good example for that, if the patient gets, for example, total thyroidectomy, and after that, for sure, we need as surgeons to ensure the hemostasis. We need to secure the hemostasis, stop bleeding before we close the wound. This is the general principle. No one will argue with you about. All surgeons should ensure or secure the hemostasis before closing the wound. Despite that, what might happen later on? For example, this patient get high blood pressure, and in the recovery room or in the ward, the patient gets just of a sudden high blood pressure, and then after the surgery, and then the bleeding restarted or has happened. As long as this is after being out of the operating room, as long as it is within the first 24 hours after the surgery, so this is labeled as intermediate or reactionary. But suppose that the patient get rebleeding or bleeding 3 days or 4 days after the surgery, and usually this is due to infection. What do you label this as? Secondary. So we have primary, as long as the patient in the operating room. We have intermediate, once the patient get out from the is it possible just to make mute of yourself, because my sound is repeated, and talk whenever you have question. So we have intermediate as long as the patient is out from the operating room, but within the first 24 hours of the surgery, and you have secondary after 2 days after the surgery. I mean. So due to infection or sepsis. Is this clear?
Yes,
Wow.
doctor.
Okay, excellent. So blood transfusion. Each unit of packed RBCs, do you think that it's 1 liter, 500, 300, 100 ml? What is the volume of each unit of packed RBC? You must know that it's 300 ml. And each unit of packed RBCs will raise up the hemoglobin around 1 gram. Suppose that the patient is having like hemoglobin of 7. So in order for the hemoglobin to reach 10, you need approximately to give 3 units of packed RBCs. So each unit of packed RBCs will approximately raise the hemoglobin around 1 gram. And as you know that the blood stored in the lab, it's up to 6 weeks. After that, that blood will be discarded. Now, what is the difference between type and screen versus type and cross-match? What is the type and screen? So I need to go fast. Type and screen. Type means the type of the blood group. The blood group, is it A, AB, or O? So B, so whatever is the blood group with RH, O negative, O positive, AB, or whatever is the situation. This is the type. So type and screen, type and cross-match. Type means the blood group and RH. What is the meaning of screen? Screening the blood against viruses, against infections, generally speaking, with a bacterial, fungal, or viruses. So the screening, this is called screening. If somebody has donated the blood need to be screened for these infections. So this is the meaning of type and screen. It's not necessarily to be the donor, but even the recipient. Whenever the patient get admitted to the hospital, we need to know whether this patient get like viruses, hepatitis C, hepatitis B. It's very important because this patient is going for surgery, and you would like to protect the surgical staff or even nurses at the ward, because they are drawing blood and all of these. So, and we are dealing with wounds. So it's very important to do at least type and screen for all patients who've been admitted to the hospital. It's very important. What is the meaning of type and cross-match? Cross-match means you are taking two samples, one from the recipient, which is the patient, and the other one from the donor. You cross them together. You put them in the same container. Even if the patient and the donor got the same blood group, they might not be compatible with each other. That's why cross-match is very important. They are crossing sample of the patient with the sample of the donor, which they both have the same blood group before the transfusion. That's why it's very important and very essential to ensure that this particular patient, once the blood get cross-match, it should goes to that particular patient. If you don't give it to that patient, it will be thrown away. So you cannot give like a cross-match blood to another patient. Thrombocytopenia, we talk about this. Platelets dysfunction and aspirin, we talk about this. Platelets should be at least 50,000 before the surgery. There's something called fresh frozen plasma, which replaces clotting factors, but the fresh frozen plasma, or FFPs, doesn't have RBCs nor platelets. There is something called cryoprecipitate, which replaces the fibrinogen and von Willebrand's factor. What are the indications of blood transfusion? There is no specific things, but generally speaking, are we dealing with acute anemia or chronic anemia? We are a bit called to give blood transfusion for patients with chronic anemia, because this is their their level. But we are sure, generally speaking, we need to replace the hemoglobin once it's less than 7 grams per deciliter. Now, what about if the patient gets acute anemia? Whenever the patient is going due to trauma, and then the patient gets like hemoglobin of less than 8, if the patient gets some symptomatic anemia, like shortness of breath, like hypotension, and the patient gets trauma, we need to give blood transfusion. Sometimes critical patients, patient being admitted to the hospital, to ICU for whatever diseases and whatever diagnosis, but the patient is critically ill. And once the patient gets like hemoglobin of 7 and low, whether there is symptoms or not, we need to replace his blood. We need to give blood transfusion. These are the checklists for before administrating blood. You need to identify the patient with the label or wristband, and ensure that the patient's label has been sticked on on the blood bag. Not only that, but you need to ensure that the blood is homogeneous, is not separated in the bag, and it's cold and sealed with no leakage. What are the complications of blood transfusion? We could categorize this into immune-mediated and non-immune-mediated. The immune-mediated, both of them could be classified into acute and delayed. Acute immune-mediated means hemolytic reaction. If the patient gets fever, if the patient gets itchiness, if the patient gets anaphylactic shock or anaphylaxis due to blood transfusion. This is acute, means that on a spot, upon the receiving of blood. Delayed means that the patient will get these complications after some times, but both of them are immune-mediated. Hemolytic reaction, or like Berbera, for example, the patient might get this after a week or 2 weeks or so. So this is delayed reaction or delayed complications of blood transfusion, which is related to immunity. Now, what about the non-immune mediated acute, like sepsis, overload of blood? That's why it's mandatory to give like laxatives in between, and non-laxative diuretics in between blood transfusion. Each blood transfusion, just to note this important, each blood transfusion will be transfused over 3 to 4 hours. And in between 2 units, for example, the patient has given the first unit, and then the patient, before receiving the second unit, the patient needed to be given like diuretics just to avoid the overhydration or overload of fluids. What about the metabolic changes or metabolic disturbance or metabolic complications of blood transfusion, like hyperkalemia, hypocalcemia, and metabolic alkalosis? These are the possible complications related to simple blood transfusion, considered as non-immune mediated. What about delayed, like infection? The patient for God's sake, hepatitis C or hepatitis B viruses. So the patient will get the infection to get appeared, or the patient to become symptomatic after some times, not immediately after receiving contaminated blood. Or iron overload. That's why you need to give iron removing agents or what's called iron chelating agents after some times, if the patient gets multiple blood transfusion. These are the risks of single red cell unit transmitted diseases. Hepatitis B, hepatitis C, HIV, bacterial. So these are the things that it's possible to be transmitted by blood transfusion. That's why it's this is in UK with very advanced techniques of screening. This might be like lab error. That's why before you give a patient any blood transfusion, think about it 100 times before you transfuse the patient. What are the symptoms related to transfusion reaction, like fever, like chills? Nausea, lower back pain, lumbar pain. Suppose that the patient get fever. What will you do? While the patient is receiving blood transfusion, the patient get fever. What you will do? First of all, you need to stop to hold the blood transfusion, and then to double check. Take a sample from the patient. Take a sample from the blood bag, which is the patient is receiving now, and send it to double check the cross match. And start the symptomatic management. The patient get fever, give antibiotic. If the patient get like rigor, you give symptomatic management. Even nausea, give antiemetic. So if the patient get lower back pain, you give analgesics. So you need to give symptomatic management. And then after that, if everything is normal and this blood is compatible and you need what you need, the next step is just to delay the transfusion. I'm talking about elective cases because sometimes in trauma cases, you need to give the blood as soon as possible. You don't need to wait for like 3 to 4 hours to be given totally to the patient, each unit, I mean, of blood. So you delayed it. Instead of giving the patient a blood over 3 hours, no, give it over 6 hours, over 7 hours. So that's why it's very important what to do if the patient get possible acute complications after blood transfusion. So for the massive blood transfusion, there are different definitions. Probably the most sensitive one is transfusing 3 units over 1 hour. We have talked about how much time you need for each blood transfusion to be transfused to the patient. We mentioned 3 to 4 hours. But suppose that you are given 3 units of blood, backed RBCs, within 1 hour. This is called massive blood transfusion. So these are the possible complications of blood transfusion: massive blood transfusion, thrombocytopenia, coagulopathy, because there is something called disseminated intravascular coagulopathy, which is due to, like, whenever you give blood transfusion, that means backed RBCs, you need to give platelets, you need to give plasma. Sometimes there is this disturbance of all of these composition, or sometimes it needed, like if the patient is critically ill, consumption. You need to give more and more of blood. Then the patient, the composition of the blood will be disturbed. Then the patient will get bleeding. So coagulopathy. This is a very important possible complications related to massive blood transfusion. Hypocalcemia, we talked about this before, and hyperkalemia or hypokalemia. Both of them might be a possible complication of massive blood transfusion related to, like, a reversed, normalization of the potassium. Hypothermia, because we are giving patients cold blood. We are not giving the patient hot blood or warm one. So this might induce hypothermia, and also acute respiratory distress syndrome, which has some multifactorial elements. It might be happen if the patient received massive blood transfusion. Do you have any questions?
Thank you,
Doctor.
Doctor.
Doctor,
Yes.
you can repeat what we do in the if we got complication in blood transfusion.
Okay. First of all, you need to hold the blood. Don't throw the blood. The blood is very important. Okay. So do not throw the blood. Don't cancel blood transfusion because it's needed upon indication. Otherwise, we didn't start blood transfusion. So first of all, you need to hold the blood transfusion. Second, start symptomatic management. If the patient gets fever, you need to give the patient antibiotic. If the patient gets pain, give analgesics. If the patient gets nausea, you need to give the patient antiemetic. And immediately you need to send the sample from the patient and another sample from the blood itself, blood sample from the bag, from the transfusion bag, and send it for the lab to cross-match again. Ensure that this blood is compatible. This blood doesn't have like a lab error. And if everything is normal, this blood is compatible, just resume the blood with lower rate. Lower rate means instead of giving the blood transfusion over 3 hours, you need to give the blood transfusion over, for example, 6 hours or 7 hours, 8 hours. So decrease the rate of blood transfusion.
دكتور
Yes.
ايش الكومن كومبليكيشن في البلد تريتمنت؟
Blood transfusion, you mean?
ايوه.
It differs whether you are talking about massive blood transfusion or simple blood transfusion. The simple blood.
Most common.
What?
Most common complication in simple blood transfusion.
Yeah, these are the things that we have said.
All of
this
them are
table.
common.
Yeah, acute immune mediated is common. Fever is common. Urticaria and itchiness is common. Delayed is common. The most common is the berbera. These are rare complications of acute non-immune, like infections or sepsis, because we have a very advanced screening process to check for viruses, to check for bacteria, but it's still there. This is common. Hyperkalemia, for example, hypocalcemia, metabolic alkalosis, this might happen. Delayed iron overload, especially if the patient get or received multiple blood transfusions. And the massive blood transfusion, these are the things. Coagulopathy, thrombocytopenia, and hypocalcemia. No? Do you have any other questions?
Doctor,
Yes.
I missed the attendance in the beginning.
What's your name?
Called.
What's your name?
Abdulqadir Salim.
When did you
But-
come, Abdul Qadir?
I came exactly at the slide of